Good afternoon.
Good afternoon.
Thank you so much for that introduction. For the next 5 minutes, I'll be talking about socioeconomic disparities in HIV, in virus suppression in Malawi. Our interest in this topic stems from an appreciation of the profound immunological benefits of virus suppression for people living with HIV, as well as the broader HIV program impacts, which are best summed up in the concept of treatment as prevention. Socioeconomic disparities in HIV treatment outcomes, including virus suppression, have been observed in multiple settings, including and more prominently in resource-scarce settings. But due to data limitations, there's been no study on the socioeconomic gradient in virus suppression among other HIV treatment outcomes in Malawi. The 2015-2016 Malawi Population-Based HIV Impact Assessment, MFIA, which was funded by PEFA, provides a new opportunity for Malawi to begin to examine some of these socioeconomic gradients in HIV treatment outcomes, and more particularly, virus suppression. This nationally representative population-based survey collected data on virus suppression, among other HIV-related variables, and it also collected additional data on household assets. In our measurement of socioeconomic inequality in virus suppression, we used what is known as the Eregas Index, which belongs to a family of concentration indices that are typically applied in health economics research. These indices measure inequality in a health variable over the distribution of a chosen measure of socioeconomic status. The values of the Eregas Index typically vary, and they range from -1 to 1. When the Eregas Index is positive, that is greater than 0, it implies that there's a positive socioeconomic gradient, and this implies that the health variable of interest is concentrated amongst higher socioeconomic groups. On the extreme, though, this can get to 1, and when it gets to 1, it means that the health variable of interest is concentrated in the highest end of the distribution of the socioeconomic status variable. On the other hand, it can be negative, and when it's negative, it implies there's a negative socioeconomic gradient, and that implies that the health variable of interest is concentrated amongst the lower socioeconomic groups. On the other end, on the other extreme, it can also get to -1, in which case it means that the health variable is concentrated in the lowest end of the distribution of the chosen socioeconomic status measure. Sometimes it can be 0 statistically, in which case there's no disparity amongst the socioeconomic groups in that particular health variable. In our study, we chose to use what is known as the wealth index, which is typically constructed using household asset data. The wealth index was chosen, and the standard wealth index, which was used in the study in the MFIA, was constructed using what is known the principal components analysis. But we do recognize that there are multiple algorithms for constructing the wealth index besides just the principal components analysis. So in order to check the robustness of our results to the choice of an algorithm for constructing the wealth index, we also constructed the wealth index again using 2 additional statistical procedures, namely the multiple correspondence analysis, MCA, as well as the uncentered principal components analysis, UPCA. Now, this slide shows us the results of that analysis. At the national level, we discovered that the EI values were not statistically significant from 0, which, like I said, in the interpretation of the Eregas Index, implies that there's no socioeconomic disparity in virus suppression at the national level. But when we stratified this analysis using the urban-rural residents, we discovered that there was a socioeconomic gradient in the urban population. Under the PCA and MCA scenarios, the socioeconomic gradient was positive, which suggests that in the urban population, the virus suppression is concentrated amongst higher socioeconomic groups. The odd result which we are seeing under the UPC scenario can safely be dismissed as an artifact of the procedure. And when you look at the rural population, what we discovered is that, again, this was mirroring the socioeconomic gradient at the national level, and there were no socioeconomic disparities in virus suppression in the rural population. Now, given the evidence that we have seen from this study, we see that there's no evidence of socioeconomic gradient in virus suppression at the national level. And these results conform to our expectations, our priori expectations. and generally validate Malawi's decentralized public health approach to HIV programming, whereby provision of ART and other HIV-related services is decentralized through primary health centers and the community. And we think this has got an important effect in that decentralization basically lifts or alleviates the socioeconomic barriers that are associated with uptake of health services in developing countries. You can consider, for example, financial means of travel to go and attend your clinic appointment. But we also do acknowledge, given the evidence from this study, that there's a pro-rich socioeconomic gradient in wealth suppression in the urban population. And therefore, we still see need for us to continue to examine the sources of the socioeconomic gradient in the urban population. And we think we can employ some state-of-art decomposition methods that are typically applied in health economics to further tease out the sources of these socioeconomic disparities in the urban population. Thank you so much. I hope I was your time.
Thank you. Please have a seat. I must apologize. I did not give him a proper introduction. Lorenzo works in the Planning M&D Research Department at the National AIDS Commission in Malawi. He's an economist by training, as you may have seen with all the graphs and figures he has told us. And he holds a Master's of Arts in Economics degree from the University of Malawi, Chancellor College. So thank you so much for your presentation. We will quickly move to the next presenter, Keshet Ronen from the US. Keshet Ronen, PhD, is a researcher whose work focuses on HIV prevention and treatment in women, adolescents, and underserved populations. She's particularly interested in the integration of biomedical and systemic interventions to achieve health equity, and most interesting, she'll be speaking about a country that I'm closely associated with by birth. Welcome. You have your 5 minutes.
Thank you. Thanks for this opportunity to present our work on food insecurity in HIV-infected pregnant women in Kenya. I have no conflicts to disclose. So food insecurity is defined as limited or uncertain ability to acquire acceptable food. Food insecurity has been shown to be associated with poor ART adherence and unsuppressed viral load in several cohorts of HIV-infected individuals. But limited data exists on the burden and impact of food insecurity in HIV-infected pregnant women, particularly in sub-Saharan Africa. It's important to look at food insecurity in this population, firstly because they may be especially vulnerable to food insecurity, given their higher metabolic and nutritional needs. And secondly, because their food insecurity has implications not only for their own health, but also for transmission to their infants. So the goal of this study that I'll be talking about today was to evaluate the prevalence and correlates of food insecurity in pregnant HIV-infected women in Kenya. So I'll be presenting a cross-sectional analysis of pregnant HIV-infected women receiving care at 6 public maternal child health facilities in Kenya. The location of these facilities is shown in the yellow dots on this map. 2 of these facilities were urban, located in Nairobi, and 4 were rural in the Nyanza region in Western Kenya. And all of the data that I'll be showing is nested within a randomized control trial, the Mobile Watch X trial, of SMS messaging to improve option B+ adherence and retention. So this is just data from enrollment in that trial. So the indicators that we ascertained were household food insecurity in the last 4 weeks using the internationally validated HFIS scale, other sociodemographic characteristics, and plasma viral load. 820 women had data that could be included in this study, and the correlates of food insecurity were assessed by univariable Poisson regression with robust standard errors. So this pie chart summarizes the prevalence of food insecurity in our cohort. We found that 41% of women were food secure, 9% were mildly insecure, 22% were moderately insecure, and 28% were severely insecure using the categories that are recommended for use with this instrument. So overall, we found that about half of participants experienced moderate to severe food insecurity, which is quite a heavy burden. This table summarizes participant characteristics that were found to be significantly associated with moderate or severe food insecurity. So we found that moderately or severely food insecure women were more likely to live in a rural region. They were on average older. They had lower levels of education. They had a lower monthly household income. They had more living children. They were more likely to experience at least mild depression, and they had lower levels of social support. Importantly, when we looked at women who had been on antiretroviral treatment for 6 months or more, we found that moderate or severe food insecurity was significantly associated with detectable viral load or unsuppressed viral load, defined as at least 1,000 copies per mil. We saw that 9% of food secure or mildly insecure women had unsuppressed viral load, compared with 16% of moderately and severely food insecure women. So to summarize, I've shown you that food insecurity is common in our cohort of pregnant HIV-infected women in Kenya, with over half experiencing some insecurity and almost 1/3 of that severe insecurity. I've also shown you that food insecurity was associated with older age, lower income, more children, lower social support, depression, and unsuppressed viral load. So moving forward, the mechanism of association between food insecurity and unsuppressed viral load warrants further analysis. This could be functioning through multiple different mechanisms, through nutritional and physiologic mechanisms, through mental health pathways, or as part of multifaceted marginalization. And finally, I think these results support nutrition supplementation or assistance for HIV-infected pregnant women to support their viral suppression. So with that, I'd like to thank the participants in this study, my co-authors, and the study team on the Mobile Watch X trial and funding. Thank you.
Thank you. Well done, Keshet. I just noted the WFP regional team walked in, so I'm sure there'll be a number of questions coming your way. But from a lawyer's perspective, just to also know that in the Constitution of Kenya, we have the right to be free from hunger and the highest adequate standard of food, and it's quite worrying in terms of what you're seeing. But not to steal the thunder from the next presenter, we are going to hear from Dr. Riley. She's a professor at the University of California, who seeks an understanding of how clinical, biological, and behavioral factors converge to influence health. Her community-based research focuses on comorbidities and competing risks in very low-income populations. So again, she's speaking to the right to housing, and that's how I'd understand it as a lawyer, which is really important. So over to you.
Thank you. You need assistance in getting the slides. Thanks. Okay. Great, thanks. I'm going to start off with something that's unexpected. At least it was unexpected to my colleagues and to me before we finished the study I'm about to describe. But here's what we found. When it comes to unsuppressed viral load among very low-income women living in a very highly resourced area, the problem isn't a failure to get care, and it's actually not a failure to get case management. The problem is what's going on in the community. It's about poverty, and it's about homelessness. So how did I get to this conclusion? Well, in San Francisco, the city where I'm from, we're lucky to have financial resources and an infrastructure that link the vast majority of HIV-positive people to care and treatment. Consequently, rates of viral suppression in San Francisco are between 72% and 88%. So the system is working most of the time. My colleagues and I are interested in the points where it's not working. We do research that spans several areas, including poverty, violence, and substance use. What we want to know is, what is it specifically about poverty and consequences of poverty that influence HIV outcomes among women, particularly when it comes to unsuppressed viral load? So to address questions like this, we developed a cohort study. Now, we knew that our study had to be different than a lot of other traditional studies because a lot of them recruit participants from places where people get care, like hospitals and clinics. But we're interested in very low-income people, and they don't always come in consistently for care. So we couldn't wait for participants to come to us. We had to go to them. So we went. We went to homeless shelters, free meal programs, and low-income hotels. We recruited 120 HIV-positive women who came in for study visits every 6 months over 3 years. At baseline, half of the women in our study were African American, 2/3 used drugs, and more than 1 in 6 had been in jail or prison in the prior 6 months alone. In addition, 60% had been in for primary care and 70% had been in for case management in the last 6 months. So that's where we started at baseline. Then we followed these ladies for 3 years. Over the course of those 3 years, we found that 2/3 had at least one detectable viral load, and 1 in 5 had a detectable viral load at every single visit. So what was it? What was it that predicted detectable viral load in this population? Well, we started off by considering 22 factors that had been found in prior research to influence outcomes in very low-income women. Out of these 22 factors, 3 stood out as being strong and consistent predictors of detectable viral load. In longitudinal analysis, the first was homelessness. For every 10 nights homeless, the odds of detectable viral load increased 10%. This means that for chronically homeless women, or those who are experiencing homelessness for more than 12 months, their odds of detectable viral load were incredibly high. The next factor was violence. Women who had experienced sexual violence by someone who was not a primary intimate partner had twice the odds of detectable viral load. And finally, incarceration. Women who had spent time in jail or prison during the study period had almost 4 times the odds of detectable viral load compared to those who didn't. These were the only 3 factors in our model. Everything else fell out of the model when these 3 factors were included. So when we consider the impact of homelessness, incarceration, and violence, and we also consider that in combination with our prior research showing strong associations between homelessness and incarceration and strong associations between homelessness and violence, it's clear that there are multiple predictors of detectable viral load. But among them, and common to each of them, is homelessness, putting homelessness at the center. So if our goal is sustained viral suppression among all people living with HIV, even people from the most challenging populations, such as low-income women, we have to consider multiple factors, but we have to prioritize housing. Thank you.
And still on the issue of housing, we move forward to Aliona, who will be speaking to us about unstable housing associated with injection risk behaviors among persons who inject drugs in Ukraine. She's currently a PhD student at Johns Hopkins Bloomberg School of Public Health, has been working on topic of improvement health outcomes among people who use substances for more than 5 years in Ukraine. Welcome, the floor is yours.
Thank you. I'm thankful to be able to be here and to present the results of our study that has focused on unstable housing association and injection risk behavior among people who inject drugs in Ukraine. This study has been motivated by the understanding that in other settings, unstable housing and homelessness are among the structural vulnerabilities that contribute to the HIV and HCV risk among people who inject drugs. Data from this study comes from a baseline survey of 684 people who inject drugs in Ukraine, who were recruited at 4 sites as part of a larger study to develop and assess the effectiveness of HIV prevention intervention. The study instrument, the survey instrument, was based on risk behavior assessment and was distributed as a self-administered survey in Russian using online-based platform. This study has been approved both by the Institutional Review Board at Johns Hopkins School of Public Health and Sociological Ethics Committee of the Sociological Association in Ukraine. As a main study, variables that we were looking into were the injection risk defined as using needle syringes after someone or sharing injection equipment within the last 30 days. And by injection equipment, I mean cotton, cookers, or water. And the main exposure variable that we were looking at was unstable housing, defined as living on the street in abandoned or vacant buildings, staying in shelter or multiple places, versus stable housing, defined as staying with friends, a sex partner, family, or in own place. We used multivariable regression analysis to look at the independent association between housing situation and injection risk behavior. And what we have found that after adjusting for the education, sex, site, and type of primary drug use, we see the independent association between unstable housing and injection risk behavior. And as this graph shows, people who reported unstable housing had 2 times the prevalence of injection risk behavior compared to those who reported stable housing. So to conclude, there are 3 takeaways I want to mention. The first one, that housing situation is part of the risk environment widely discussed in the literature. People who report being homeless or having unstable housing are likely to represent one of the most marginalized populations whose vulnerability to HIV and HCV are substantially higher. Therefore, this study highlights that among the other programs that exist in Ukraine, assistance with obtaining stable housing and additional psychosocial support should be among the services that cover the additional prevention needs among this subpopulation. And third, despite the abundant evidence of the precarity of the socioeconomic precarity of health outcomes, this avenue of research has not been fully explored in regard to HIV and HCV risk in Ukraine and Eastern Europe and Central Asia. And our findings, though not new, but bring the light to the fact that structural determinants of health should be addressed as part of the programming and implementation to prevent HIV and HCV in this part of the world. And to conclude, I would like to thank the whole team, the participants, and agencies that have been worked, and their input has been essential for this study. Thank you.
So before we come to the floor, we'll get to hear from the final presenter. Goldenberg is an assistant professor of health sciences at Simon Fraser University and research scientist at GSHI, a Center for Excellence in HIV and AIDS. She has over 10 years experience in community-based research on HIV, STIs, human rights, and access to care among key populations of migrants and sex workers. Welcome.
Thank you very much. So before beginning, I just want to acknowledge that this work is the product of a deep collaboration between academics, sex workers, and community-based organizations, as well as health service providers in Vancouver, and I'm grateful for the contributions of our academic and community co-authors here. So there's been mounting interest in better understanding the impact of place or social geography in understanding HIV-related inequities. Prior research has shown us, using geographic methods and others, that policing, stigma, community harassment can all displace sex workers to unsafe environments. And this has also been linked to elevated HIV and STI risks, as well as reduced health access. There's been marked increases in gentrification in Vancouver and many other similar cities in recent years. In Vancouver, this is particularly intensified in the past 8 years, since about 2010, at an unprecedented rate. The downtown East Side community, which many of you may be familiar with, is frequently referred to as the epicenter of the substance use and sex work scenes in Vancouver, and the home of places like Insight, our supervised injection facility, has been particularly impacted with low-income housing and single-room occupancy hotels and social housing being upscaled into new and luxury condos, which have been termed zones of exclusion by local community residents who've expressed particular concern about this. Despite these concerns, little is known about the impacts of such gentrification on work and living environments or health and social services access for sex workers and other marginalized populations. So our objectives were really to evaluate these changes following gentrification and to model impacts of exposure to the gentrification time period on service utilization. So we compared sex workers' experiences in the study between 2010, when things began to really intensify, and the beginning of our project, and 2014, 4 years later. Data were drawn from an evaluation of sex workers' health access, the Aisha study. This is a community-based study of sex workers operating across diverse indoor, outdoor, and online spaces across Metro Vancouver. Our staff involves current and former sex workers represented across interviewer, outreach, and nursing, and increasingly academic teams, which we think is extremely important. Our project involves 10 location sampling across diverse areas of the city. And we conducted a before and after analysis and GIS mapping using data from our cohort, as well as publicly available land use data using geographic methods. So I wanted to share two maps with you before getting to the epidemiological analyses. So in this map, you can see the blue areas which represent residential land use and the red representing commercial and industrial use. And what this figure shows you between 2010 and 2014, there was a substantial shift towards residential and newly built housing in the downtown East Side and Strathcona neighborhoods where many of our participants previously worked and lived. And when we looked at data from our cohort, what we saw was that rates of outmigration from these areas were quite high and really indicated strong outmigration from these neighborhoods towards surrounding areas in the same study period, which based on community reports, previous research on this land use data, we attributed to potential changes resulting from gentrification. And in our study questionnaire responses as well, we observed an increase in the distance between participants' place of residence and where they worked from the downtown East Side core, and a shift away from street-based towards online and informal indoor sex work, suggesting displacement might account for this change. We were surprised to see changes in the uptake of HIV testing, STI testing, sexual and reproductive health services, and sex worker-specific services such as outreach between the same period. This is despite intensifying test and treat efforts across Vancouver that many of you may have heard of. And in an adjusted model, we found that the gentrification period was linked to declines in all of these services between 2010 and 2014. And really this linked to the period of unprecedented gentrification, despite these mounting HIV efforts that I mentioned. And what this really means for us is that efforts are needed to promote access to safer work and living environments for sex workers and to support sex worker-led and specific services across various parts of the city, including in response to changes in where folks are working and living. And I just want to argue that this really parallels a lot of the messages we've heard from our speakers earlier in terms of housing and poverty and what's happening in our communities, really telling a big part of the story when we talk about access to HIV care. I want to acknowledge the expertise and contributions and time of our participants, our staff, funding, community advisory boards. Thank you very much.
Awesome. I'd like to thank the panelists for sticking to time. It means they've allowed us to have room for enough conversation. And just to frame the argument from how I'd understand it from a human rights perspective, we've been speaking about structural barriers to accessing healthcare services, and we've largely looked at the aspects of accessible and adequate housing and reasonable standards of sanitation. We are looking at issues around to be free from hunger and to have adequate food of acceptable quality, listening to our colleague from Malawi, looking at the poverty and social security issues that are quite important in terms of ensuring they need to be addressed to be able to ensure that people are able to access healthcare services. And so the participants have used quite important information and studies that are going to be informative. And so now it's our chance to give them feedback, to ask questions, to have comments. The only thing I will request you to do is to step over to a mic, let us know your name, let us know who you're directing the question to, and if you can keep it short and simple, that will also be great. Mic 3.
Hi, my name's John Harriet. I'm from Toronto, U of T. I've also done some similar research around like the social determinants and the impact on viral load. So I just had a question for folks from Vancouver and San Francisco. Once you have this sort of data about housing or gentrification and how it might impact HIV care, do you guys have any examples of what you guys are doing currently to like take this research and talk to stakeholders or politicians or whatever? And I'm curious what your next steps are going to be or what you've already been doing in that area. Thanks.
Great. Mic 2.
Hi, thanks. Alison Oman from the World Food Program in Nairobi for the region. Keshit, it's for your presentation. I mean, it's fascinating for us. We find that we're having a lot of battles, especially with key donors, around this idea that there's no real clear link between nutrition and HIV. and that all of the work that we did a decade ago, where it was absolutely standard that we would be supporting people living with HIV with adequate nutrition when they're food insecure, has now been considered really passé. And they say that we can't make the link. And I think that this research that you've done, I mean, is fantastic for us. We have a lot of operational research, especially that we've done in Southern Africa, that showed absolutely higher rates of HIV transmission amongst populations during the El Nino crisis, and people that the real link between food insecurity and malnutrition for people living with HIV, but we really haven't been able to get traction because we're told these aren't formal research, this is operational, you haven't controlled for all the variables, which we won't do because we will just go ahead and do the implementation and hope we can show. So we would love to work more with you on your research in order to advocate for people living with HIV, and in particular, you know, the work you did with pregnant women, which is of particular concern to WFP. So we'll talk to you later.
Thanks. Number 4.
Hi, can you hear me? Okay,
Yeah.
yes. I'm Linda from Malawi Liverpool Wellcome Trust in London School. Obviously, my question is to the Malawi presenter, Lonje. So I was curious in terms of the measure of socioeconomic status that you used and how it compared with any most recent national measures of socioeconomic status as well.
Hi, thank you, everyone. My name is Leanne Evanson. I'm on the board of an organization called HIPS. They work with sex workers and drug users in Washington, D.C. I think that the issues that you guys raised, this is probably the most exciting panel I've attended. I wish that somehow we could get this conversation along with it feels like everything old is new again. We're going to talk about using condoms. We're going to talk about engaging men. And the conversations, I've been a little depressed at the fact that the conversations don't seem to also take into factor of like, why aren't these things happening 30 years since, or, you know, we were here in 1992 saying the same things. Do you have any sense of how we are going to bring together the social determinants, the things around, like if we're criminalizing homelessness, and then that's increasing HIV risk, or we're gentrification and these social issues that we're seeing everywhere. It's not just in the United States. It's in Nairobi. It's in Lusaka. You see people being pushed out and having problems with housing and finding food. Is there any sort of connection that is being made? And I don't know, maybe there are people in the room that know this, since you all the researchers. I'm trying to figure out how do we bring this together to programming. Thank you.
Rob Knowles from the United States. I'm wondering, with homelessness and viral suppression, did you see a difference between like homelessness and couch surfing and shelters and permanent housing? Did it matter what type of housing folks got into?
Great. I will let the brave one start off, so choose among yourselves.
I'm happy to start. Is this on?
Yeah,
I'm happy to start in response to the question from our colleague from U of T. So in terms of the next steps in some of our work, so the gentrification work is emerging. This work will be published, following the conference. But based on our previous work around housing and other social inequities being strongly linked to sex workers' health access and health outcomes, for example, like our health authority, Vancouver Coastal Health, had a strategy around kind of improving services in marginalized communities in Vancouver. And they were quite critiqued for not having a sufficient focus on some of these gender-specific issues. And so our research had the opportunity to inform a companion paper that went along with that talked about many of these issues and issues around housing, mental health, and other intersecting concerns, which is now informing the rollout of some new services. But for example, like a mobile women's health support team. But what I will say is that we're still facing the same problem of many of these services being concentrated in these areas where people are being pushed out of. And as I'm sure many in this room are familiar, public health is quite slow to respond to these changes. So we continue to push. We also work, both our own team and community partners do a lot of mobile outreach. So I think our work has an opportunity to directly inform that. We advocate for broader decriminalization of sex work because that's truly what enables these sex worker organizations and outreach to really take place, without fear. And lastly, some work by colleagues at GSHI, including Dr. Andrea Cruci, has shown that there are really important supportive housing models that are quite innovative actually in Vancouver. For example, some of these single room occupancy hotels I mentioned have like a women specific and non-judgmental sex worker supportive model where there's a lot more safety and protection. And so we've advocated for the scale up of those models, and some of those groups came out quite publicly when that research was launched, and our housing agency did not they ended up supporting the statement instead of going against it, which was innovative at the time. So we have seen some progress in Vancouver, but we have to keep pushing. Thank you.
To answer the gentleman's question briefly, the main effect we saw was literal homelessness, but I have a lot more detail on that I can tell you about later if you're interested. And the other question about are people doing something about or something with our research, I'm actually really excited to say that in San Francisco the answer is yes. That our health department has there's a Getting to Zero program, and within that program we've been sharing a lot of our data with the Getting to Zero program, and we've been talking a lot about housing and what's going on in San Francisco, and specifically in the division where I work in Ward 86 in San Francisco. There's a whole campaign on healthier when housed. So there's not only a recognition, but it's really being taken up by our division chief, our nurses, our social workers, our docs. We are all seriously talking about it a lot and bringing it into talking about how do we bring this into the clinic? How do we influence policy? In San Francisco, it's easier because in San Francisco there's a lot more, I won't say acceptance and a lot of support for wanting to do this type of thing. So there's less supportive housing funding right now than there has been historically, which is a problem, and so we're having more homelessness. But I would say, again, the city is aware, and there's navigation centers which are housing people more. The health department is trying to incorporate it in their programming, and our clinic is as well. But I'd have to say that this is also happening in a country where there's a lot less support now for social programming, and it's getting worse all the time. And so we are this tiny little pocket of support and trying to have better programming and trying to further this when there's less funding federally, and all around us it's getting harder and harder. So your question's good. Thanks.
Just keep talking.
Okay. Thanks for that question, Linda. Ideally, I think would have loved to do a sensitivity analysis and check how our results are robust to the choice of a socioeconomic measure. But unfortunately for the MFIA dataset, they were only able to collect household asset data, for which I think we could now use to construct the wealth index. Unfortunately, the literature suggests that the wealth index is also a better measure of a longer-term socioeconomic status than income and consumption. So I think we have got confidence in our results because of what the literature is saying about the reliability of the wealth index. But otherwise, I think if we didn't have this data limitation, we would have loved to check the robustness of our conclusions to the choice of a measure of socioeconomic status. But that's an interesting question, and I think if data would be available in the future, we'd love to conduct this analysis again and then check how the results would shift if we employed a different measure of socioeconomic status.
And just to respond to the World Food Program person, yes, let's talk. And I think that, I guess my response there maybe partly addresses the other question about kind of moving this into programming. I think that these analyses, because of the interrelated nature of all of these different factors, I think can be quite challenging analytically. And I think for me, sort of coming from an epidemiologic perspective and as a researcher, I think we need to move into studies that generate evidence that interventions work. And I know that in the context of food, I know that there is a randomized trial happening right now for food supplementation. So I think that's sort of a direction that I see this work needing to go.
So we have time to take a round of probably 4 more questions. So in case you asked a question, you're not happy with the responses, or you have more to add, this is your chance to do so. I see one person at the mic. But before I allow you to speak, I just want to say I agree with the lady from HEPS who made the comment that we need to do things differently. Because for me, and I don't work for the IS, but I'll communicate this to them, It would have been good to have a lawyer, well, there's a lawyer here now, but it would have been to have a politician, a funder on this panel to be able to have that debate around, is nutrition important? Why is it not being funded? Or if people do not have good housing, what kind of changes will we make in terms of laws and policies? And how will governments work towards increasing their budgets to address some of these structural issues? So I do agree with you. We need more of those panels and conversations to be able to get answers and ask the right people the right questions, because the feeling I've gotten in many AIDS conferences is that the scientists will speak to themselves and the human rights people will speak to themselves, and then we'll all go back home and do the same thing over and over again. So we need to find a space that gets both of us together and have that particular conversation going on. Over to you.
Hi, my name is Stan, and I had a question specifically for around the issue of homelessness, housing justice, and displacement, particularly in San Francisco. Is there a government interaction between the Bay Area, San Francisco, and then Oakland and other counties where these people may be going to and not simply staying within San Francisco, and perhaps even some experience from the Vancouver experience?
So interestingly, with our study, we recruit homeless women, and going to the venues where we go, homeless shelters, free meal programs, low-income hotels, the median age of the ladies in our study are about 49 years old. And because they are HIV positive and they are around almost 50, this particular population isn't super mobile, but I know from working with colleagues who follow particularly young injectors, much more mobile. But the ladies in our study pretty much stay in San Francisco, and the services are better. There's a lot more integration of other services, and so they tend to stay put. But again, I think it has to do with age of who you're talking about. And in terms of between San Francisco and Oakland, there might be some movement, but I do think that it's really challenging, particularly for homeless folks to have resources to get on the train and get on BART and what have you. And so I've actually seen participants from our study on the other side of town and they say, "Hey, what are you doing all the way over here?" And it's just a big deal for people to even get across town. So not a huge amount of mobility.
And I can just add insights from the Vancouver research, which took place over a 4-year period of time. So between 2010 and 2014, we did see quite a few people change the neighborhoods in which they were living and working. Getting across town is still a big deal. So what we saw the impact of that on was access to supports. So as I mentioned, most of the harm reduction supports, sex work specific services really tend to concentrate around a particular part of town, and most people were moving to other parts of town because of this gentrification and displacement. And so there are some mobile services in those areas, but not enough, very limited funding cuts, and a limited capacity. So we need to support those groups to be able to meet women where they're at, to really make services more accessible, as well as think about housing models that are more supportive and available to folks so that they can choose where they want to live.
Go ahead.
So I was just wondering, in San Francisco, so you focus on women, do you think it would also apply for homeless men? I was just wondering why you specifically chose women in that study.
That's a very long story. It's a good question. To make a very long story short, in 2 studies ago, we were following both men and women. And in that study, what we found was that 2 studies ago, we kind of came to this conclusion that there was a lot of violence that led to the last study, which is not this one, but the previous one, and that men and women were both experiencing violence, and a lot of it, but it was very different. Like how they were experiencing it and the context in which it was being experienced was different. And so what we chose to do was to focus on one, mostly for financial reasons, because we would have had to have a huge cohort and then look at restricted analysis. So in order to be able to focus it on the issues that were specific to women, we focused it on women. And then out of that came some other issues that we went to the next study. So it was mostly on being able to focus on issues specific to women, so we could have one cohort and not have to have a lot more money to have a bigger cohort.
Go ahead.
Hi, my name's Yue, and I'm from Simon Fraser University. So I have a question about if you see a more negative impact on, for example, illegal immigrants who are sex workers or temporary immigrant status sex worker or racialized community members.
Thank you very much for that. I'm from Simon Fraser University as well. Yeah, so we actually do a lot of work with migrant sex workers. Importantly, an important clarification to make is that in our study context, and I think what we've seen in the data at large, is that almost all do have legal status in Canada. There definitely are issues around a lack of access to work permits, and actually sex work is the only type of work that's explicitly prohibited on an open work permit in Canada, so there's some serious issues around that. So there definitely are, but in our study, the majority did have a status, but we are doing some work now around precarious status and how that impacts access to health and safety and justice. And for precarious status, we are also defining as like dependent on an intimate partner for status, because we do see very high rates of violence in our study at large, and we believe that that's incredibly important to learn more about. For the gentrification study, most of the migrant sex workers, who do make up about a third of our cohort, were not included in that particular analysis because we were looking at people moving out of the downtown east side, which tends to be more the Canadian-born women in our study. So for this particular analysis, it didn't pertain to the racialization aspect for migrant workers. We did have an overrepresentation of Indigenous women in the study, though, who are also very racialized, but we didn't have significant differences in gentrification experiences for that group. Thank you. It's an important question.
Awesome. Having seen no other questions, I'll give it. Okay.
So, sorry, I have one other question.
Sure.
So I'm wondering if anecdotally, specifically for sure, anecdotally, have you seen, you talked about the people going online and perhaps thinking that that was an issue of displacement. Have anecdotally you seen a reaction to the anti-trafficking laws in the United States, the SESTA and FOSTA, that have shut down a lot of those online sites internationally as well? And if people are now back on the streets? I know your data is from 2014, but if you've seen that.
No, we do have, thank you so much, great question. We do have updated data, and we're actually doing an analysis on that right now. We have seen increasing online sex work in the last few years with rising use of the internet generally, and we're evaluating the impact of the FOSTA SESTA laws more recently on whether or not there have been changes. What we do see is that opportunities to work online tend to be associated with more access to safety and important protections, abilities to screen clients, so we're very concerned about those impacts, and we'll be looking at that further. I'm happy to chat about that afterwards. Thank you.
Awesome. So I'll give each of the panelists less than a minute to give their concluding reflections from what you've heard and how you're going to move forward based on this feedback. And I'll start here.
Yeah, thank you so much. Like I indicated in the presentation, there's still need for us to go ahead and examine sources of the socioeconomic disparities in the urban population. And I think given the comments that we just got about the need for us to conduct a sensitivity analysis to check how our conclusions might shift if we had different measures of socioeconomic status, I think in the future, if data would be available, we would try to conduct that sensitivity analysis. But I think fortunately, the literature so far gives us an impetus to still go ahead and use the wealth index as a measure of socioeconomic status. But I think moving forward, we can still just go ahead and do the decomposition analysis to see what are the sources of the socioeconomic disparities in the urban population. So thanks so much for that feedback. We'll proceed accordingly.
So thanks everyone for that feedback. It's been really wonderful to be part of a panel that is thinking so intersectionally, as other people have commented. I think for us in our own research, I think continuing to sort of dig into the mechanism of this effect, and also working closely with advocates and agencies to think about what is the type of data that we can provide to build a case for addressing these issues. I think that feels like a very important conversation to be having.
Wow. I think that adherence interventions and retention and care are super, super important. And when you're in a really high income, high resourced area, it goes beyond that. And it goes down to basic subsistence needs like housing. And it's important to have policies and programs within clinics, and that's what we're trying to do. But I think beyond that, there needs to be larger policies around funding and housing people, and more supportive housing. And we need to affect policy by this.
As a person coming from the low resource setting, I would say that unfortunately having a huge delegation from Ukraine at this conference, I can see very few faces here from Ukraine. And I think this is one of my main tasks, to keep bringing this question to the focus, that structural vulnerability exists in the countries where generally there is the low socioeconomic status, but there are additional subgroups whose conditions put them at additional risk.
Thank you. It's been a privilege to be a part of this panel where I think we've heard the resounding theme of issues around housing insecurity, and other economic determinants of health really explain hugely access to care and gaps in care for marginalized populations in the context of HIV. I think for us, we really want to argue more for housing interventions and mobile interventions as well that support sex worker community to meet people where they're at, but also housing interventions that support sex workers to work and live safely. And I think just more broadly, work around the impacts of poverty, housing, and displacement when we talk about implementation science and the rollout of various HIV cascade interventions. I think we need to be think very carefully about how these structural impacts shape the interventions we're talking about, and make sure we're addressing those adequately alongside the biomedical and clinical and behavioral pieces of this field. Thank you.
So thank you to the panelists for your great presentation and information, and for those who have contributed to questions, and for those who sat in and listened. I will not dare summarize what was all said, but my take home here is that I need to find a way to get the scientists to go into the non-scientist sessions, and to get the non-scientists to come into the scientist sessions, so that we can have a proper conversation at this AIDS conference if we really want to end HIV by 2030. So thank you all, and a big round of applause.